I'd like to welcome everybody to the first trauma critical care grand rounds of this new academic year. It gives me great pleasure to introduce Laurie Grier, who most of you know. She's going to talk about a topic which is increasing in importance. It's got the attention of the Critical Care Society, and that is sepsis in the hospital, sepsis in the ICU. It has recently been redefined, our approach to it has been redefined, so we asked her to come and talk and describe where we're going with this now. Laurie?
Thanks. Can you guys hear me in the back? John, everything good? Excellent.
Are you qualified to give this? You only have 4 professorships.
I am not qualified to get this. Not at all. But I can read a slide like anybody else. All right, guys, thanks for coming today. Typically, the first conference of every year, we try to do a joint conference between critical care and trauma and give something that's going to affect everybody in their group practice. I'm glad to see some pediatricians, some OBGYN folks, some PharmDs, emergency medicine, nursing. Am I missing anybody? I don't want to miss anybody. I don't want to insult anybody. Medical students, everybody, OMFS students, thanks for coming, guys. We appreciate y'all doing that. Crystal, truly appreciate you more than you'll ever know, darling. If it wasn't for this, I wouldn't be here. So we really appreciate it. But what we're going to do today is we want to talk about sepsis. Because let's face it, it is becoming one of the new vogue terms when it comes to critical care. Everybody's going to see it no matter where you practice, whether you're a radiologist, you're a pathologist, or you're somebody that's really in the midst, in the ground, doing the work that we're doing. And when we talk about sepsis, something like that that's so important and something that crosses so many barriers, Vernon's Law always comes to mind. And that says that experience is the worst teacher. It gives the test before presenting the lesson. So for all of you that are just starting out, or those of you that aren't very familiar with this disease process, we're going to give the lesson before you guys get the test on the wards and in the ICUs, so you know exactly how to take care of these folks. We're going to talk about the history of sepsis. We're going to talk about the new concept of sepsis 3. We're going to talk about how we take care of these patients, and we're also going to touch on the early goal-directed therapy controversies, because that's been a big deal in the literature in the last 2 years as well. So when we look at this, and I want to thank Dr. Judy Lactate for a couple of these slides. This is one of hers. In that when we look at the definition of sepsis and we think about a disease process that all of us are taking care of, when did it really first start? When did we first start recognizing it? It goes back a long, long time ago. As a matter of fact, Machiavelli actually describes it as the physicians say it happens in hectic fever, that in the beginning of the malady it is easy to cure but difficult to detect. Totally true of sepsis. It's easy to treat at that point in time, but most of the time we're not going to see the patients at that point. But in the course of time, not having been either detected or treated in the beginning, it becomes easy to detect but difficult to cure. Totally true when we talk about this particular disease process. As a matter of fact, Hippocrates talked about it. Sepsis is the process by which flesh rots, swamps generate foul airs, and wounds fester. I kind of like the other guy's definition just a little bit better. Galen said it's a laudable event necessary for wound healing, and Pasteur, of course, called it blood poisoning. So what do we call it? Well, we call it sepsis. And although we've described it, we've seen people talk about it 1,000 years ago, but one of the things that we, as critical care physicians, one of the things that we really saw in the 80s and early 90s is that nobody really cared about it. It wasn't one of those disease processes that when you said sepsis, you got everybody's attention. As a matter of fact, it wasn't until the mid to late 90s and early 21st century that people really started paying attention to it. And the reason why it came to the forefront was because famous people started dying of sepsis. And it made the news. Superman, the Pope, Kermit the Frog, all of them died from pneumococcal pneumonia from sepsis. Patty Duke Austin recently just died for an intra-abdominal septic source. Now, because people like this are starting to hit the news, lay people, everyday folks that weren't really paying attention to it, are starting to want to know more and more about the disease. And when you say sepsis, how many times have you said that your loved one has sepsis or severe sepsis or septic shock, and your patient's family goes, oh, you mean like Superman had? So they're starting to make that particular connection. We've seen a patient similar to this. Some of you have probably seen this slide before, but it's a patient who's critically ill, who's got multi-organ dysfunction. As you can see, he's intubated, so he's got respiratory dysfunction. He's got a PA catheter in, so we know this is an unbelievably old slide. So he's got cardiovascular dysfunction. Neurologic, he's tied down. He's got thrombocytopenia from his purpura here, and you can see some edema of his tongue, so you know he's probably got some sort of renal impairment from there. So we know he's got multi-organ dysfunction. But what do we know about sepsis? Why do we care about it? Well, severe sepsis itself is a major cause of morbidity and mortality across the world, but in the U.S. itself, it's a leading cause of death in the non-coronary ICU. As a matter of fact, it's moved from the 11th to the 10th leading cause of death overall. So how many people every year get sepsis? They kind of guesstimated about 750,000. But in all honesty, when you look at ICD coding and stuff such as that, you're probably missing a significant number. So I think that number is a lot higher than we see. And when you look at the mortality overall, it's about 28.6%. Very, very specific on that number right there. But as patients get older, patients are more immunocompromised, other things come into play, other medical comorbidities, that mortality will go up significantly. So over 200,000 people per year die, about 600 people or more per day die from severe sepsis. So it's a big game changer. It's a big player in healthcare. We need to be aware of it. Now, when we compare it to some of the other disease processes, such as AIDS, different types of cancer, and congestive heart failure, the incidence is significantly higher. However, research dollars and knowledge about the disease process is significantly lower than all those diseases. And again, when you look at mortality short of coronary, it's right up there with it. Because how many patients die from cancer? How many patients die from AIDS? They don't. They die from a complication of their disease process, and most of those folks, the complication is going to be severe sepsis. Now, based on all of that, people started paying attention, started noting it, and they're like, well, how do we treat it? How do we diagnose it? As a matter of fact, in the early 90s, late 80s, some of you are old enough to remember those days, some of you weren't born yet, but that's okay, we don't really mind. What they would do is there was something in your office. It was tethered to the wall. It's called a telephone. And sometimes you would get phone calls on this machine. It would ring, and you'd actually pick it up. There'd be a human on the other side. And other times, you would go to this area called a mailbox, and there'd be an envelope in there with papers. And we would get paper surveys. And on all those surveys, what they would ask is they were asking, what was our definition of this term or that term? And based on a lot of those results, a task force was created with these particular gentlemen that met in 1991. And their specific job was to take these terms that we'd all been handed on either phone calls or by paper and give us true definitions. And at the end of their meeting, they published this article that came out in Chest in 1992 with what they felt was the diagnosis or the definition for every one of these particular diagnoses, so that everybody was on the exact same page. So that if I said a patient had severe sepsis, everybody knew what I was talking about. It was very, very similar to when we talk about cancer patients and we talk about staging. Everybody knows what that means when you say somebody has cancer with this particular stage. Everybody's on the same page. And that's kind of the way it was with these particular definitions in 1992. In 2001, they changed their task force, added some other folks from the European Society, ATS, and the SIS, and they met again. And it's like, let's take a look at those previous definitions and say, do we need to advance them? Do we need to change them? What do we need to do to them so that we're staying up to date with the times? And as a matter of fact, those 6 definitions, they kept. They kept them the same. They said people are finally able to talk to each other. Everybody's on the same page. Let's just leave them as they are. They did expound on them somewhat, but overall, those definitions stayed the same. Such to the point that when you look at the continuum of sepsis, that you would look at a patient that would have an infectious process. Now, when we think infection, what's the first thing that comes to mind? We always think bacterial. But keep in mind, it doesn't have to be. It could be viral, it could be parasitic, it could be fungal. Anything that can cause an infection was considered in this particular continuum. Your next stage was something called SIRS, or Systemic Inflammatory Response Syndrome. Now notice there's no arrows going this way. This is one item, this was one entity itself. And there were 4 criteria to SIRS. It was alterations in temperature, either hyper or hypo, remembering that patients that are actually hypothermic are actually sicker than hyperthermic patients because they can't mount that temperature response to a process. Tachycardia, of which we all learn in first semester of medical school that tachycardia is greater than 100, but I don't know, for some reason these guys went with greater than 90. Changes in respirations, they use greater than 20. It's been advanced to tachypnea, anybody requiring any form of mechanical ventilation, whether it be non-invasive or invasive, and anybody with a PaCO2 less than 35 all meet this criteria. Then alterations in white blood cell count. Now keep in mind that infection is over here, SIRS is over here. SIRS is just a marker of inflammation. It's not necessarily a marker of infection. For example, if I asked you to go outside, hit the stairs, run them 2 or 3 times, come back in the room, just about everybody in this room would meet SIRS criteria. The stairwells are not air conditioned. You would be hyperthermic. You would be tachycardic. You would be tachypnic. And you would demarginate some of your white blood cells. So everybody in this room would have SIRS. But are you septic? No. Keep in mind, it's a marker of inflammation. Anything can give you that, whether it be from significant exertion, pancreatitis, burns, trauma, obstetric emergencies. Any of those things can give you a SIRS response. Doesn't mean that you're septic. However, if you add a presumed or confirmed infection to 2 or more SIRS criteria, then you were at that particular point in time in history, you were considered to be septic. If you added an organ dysfunction to this, you had severe sepsis. And if that organ dysfunction was cardiovascular, where despite what you consider to be an appropriate volume resuscitative effort, you remained in shock, you developed what was at that point in time defined as septic shock. Now, with all this, Balk and their group said, okay, that's cool. Let's define the organs. If we're going to talk about organ dysfunction, what are the organs? And we always talk about the big 3. We talk about respiratory, we talk about cardiovascular, we talk about renal, right? When you think about organ dysfunction, those are the big 3 that you're thinking about. But there's actually 7 organ dysfunctions that you look at when you look at this particular continuum of disease process. You look at neurologic, altered mental status, decreased level of consciousness, decreased Pascal coma scale. You look at respiratory, like we've talked about, decreased PF ratio, anybody requiring any form of support, whether it be non-invasive or invasive. You look at hepatic, look at their liver enzymes. Are they 2 times the upper limit of normal? I'm going to go over here. You look at heart for cardiovascular. Are they tachycardic? Are they hypoperfusing? You have to give them some sort of vasopressor. You look at renal, look at their urinary output is less than 0.5 cc's per kilo per hour. Have you doubled your creatinine? Do they require some sort of dialytic therapy? And then the last 2. And the reason I say the last 2 to me, because these are 2 of the most important organ dysfunctions that don't get enough credit. And the reason why I say that is because when you look at hematologic dysfunction, thrombocytopenia in the septic patient is prognostic. How fast did they develop the thrombocytopenia, and how severe is that thrombocytopenia? The faster they drop their platelet count, and the lower that platelet count goes, the higher the risk of mortality. Back in the day, when I say the day, I mean when I was a resident and I was a fellow, we always looked at it as being septic shock with or without DIC. We now know that DIC is part of the organ dysfunction, and therefore it's one thing. So that's why hematologic is so important. The other one that's extremely important is metabolic. Is the patient in aerobic or anaerobic metabolism? If they are anaerobic, that is an organ dysfunction. You measure their lactate. If their lactate is elevated, it's a marker of hypoperfusion, it's organ dysfunction, and it counts as one of the 7. Now, why is this important? Well, it's important because as we increase the number of organ dysfunction, we increase the mortality of our particular patients. Now, Vince Salt and their group took a look at it and said, that's pretty cool, but does it really work? I mean, the other studies were kind of old, so they looked at it, and they said, what percentage of patients really meet criteria for organ dysfunction? Well, most of them don't have many, so they're just septic because they meet SIRS plus the infectious component. But as you add number of organ dysfunctions, you start to see your mortality rate actually does continue to go up. I'm not really sure where these guys practice, but I can tell you right now, if they're going to make our ICU, they're going to have 4 or more organ dysfunctions, as simple as that. This number is pretty low. I'd like to see this done. This is in the European intensive care units. I'd like to see it done in an academic center. Here in the U.S., I think our numbers would be a lot higher in the number of organ dysfunctions that patients have. So once we know exactly where we are, we know what the disease counts, we know where we've been, how do we take care of those patients? What is so important? How does this happen? What do we have to recognize as the pathophysiologic problems, the pathobiology that's occurring in these particular patients? And I'd like to say that I'd like to cover all that, but that will require hours of which to talk about. But what we do know is that we have a pro-inflammatory and an anti-inflammatory component, and they're fighting each other. Your pro-inflammatory component looks at the pathogen itself, the load, the virulence, and the associated molecular patterns, what type of enzymes, what type of molecules are released with that particular pathogen, and it fights the host cell, the host factors, your environment, genetics, age, other medical illnesses, medications, all of that kind of comes together. And when you put these two together, you start moving this direction in your cascade. And you start to see leukocyte activation, you'll see complement activation, you'll see coagulation activation, and as all this occurs, you start to see problems with the cell itself. With your host factors, all of these other enzymes are released, and you start to see things moving in that particular direction as well. Now, as all of this is occurring, what you're going to see is you're going to see a change at both the microcirculatory level and at the tissue level. In the microcirculatory level, you're going to see increased coagulation, decreased anticoagulation, and you're going to see problems with loss of barrier function and shift of cells and fluid being able to move in and out of the capillary areas. As all that's occurring, vasodilation, hypotension, decreased red cell deformability, you start to see hypoperfusion of the tissues. As you hypoperfuse the tissues, you start hypoperfusing the mitochondria. And this is probably one of the most important aspects of sepsis itself, is because if you hypoperfuse that mitochondria, you're going to shift from aerobic to anaerobic metabolism. When you make that shift to anaerobic metabolism, you shift in how much ATP that particular mitochondria can make. When you have a healthy, perfused mitochondria, it's making what? 38 ATP per cycle. It's kicking in, and no matter what you throw at that cell, it's fine. It's like, bring it, I got this. However, when you shift it to anaerobic metabolism, it makes 2. And when you make 2 ATP, your supply and your demand ratio is a little bit different. And the more demand you put on that cell, the less ATP it can make, the more likely that you're going to start to see dysfunction and eventual cellular failure and organ failure from there. So to simplify those past 2 slides, what you see in the pathophysiology is microvascular dysfunction with increased inflammation, increased coagulation, decreased fibrinolysis, leading to microvascular thrombus, therefore hypoperfusing the cells and shifting over, like I said, to anaerobic metabolism and tissue damage and cell death from there. So when we look at sepsis as a disease, we consider disease of the microcirculation. And that makes a lot more sense because think about it. You have a patient that comes in with a UTI, a patient comes in with pneumonia. How do they go from a single infectious process in one area to entire body failure? How does that work? Well, it works because it affects the microcirculation. And once that starts, it doesn't stay in the bladder. It doesn't stay in the lung. It just shifts to the entire body. And that's where we get multi-organ failure in our disease processes. So from that standpoint, we had our definitions. We kind of had an idea of the pathobiology that's going on with the disease process. How do we take care of the patients? 2004, Surviving Sepsis campaign took off. This group of folks got together and they're like, okay, we've got our diseases, we have our definitions. How do we want, or how do we feel it's best to treat these patients? What's the best way that physicians that aren't on the front line, docs that aren't at academic centers, people that aren't reading every article as it comes out, that's not really as up to date, how can we give them some sort of protocol to move forward to manage their patients? So what they did was they did what everybody does. They took a look at the evidence. They graded it for level of evidence as well as level of recommendations. From there, we got this. This was the original grade of evidence when it came to the Surviving Sepsis campaign, which came out in 2004. Everything from A to E based on how much evidence-based medicine there was out there to something as simple as case presentations. And they put everything in that particular grade, and from there, we got the infamous, might I say, bundles, the 6-hour bundle and the 24-hour bundle. From that particular standpoint, these were released in 2004, New England Journal, and they were said, here you go, folks, go forth and conquer. Here's how you take care of the severe sepsis patient. In the first 6 hours, you're going to measure lactate, you're going to get blood cultures, you're going to get broad-spectrum antibiotics, you're going to volume resuscitate the patient, vasopressors if you need it, monitoring your patients, and adding inotropes is from there. After 6 hours, your goal was to tight glycemic control, dorticlogen alpha, steroids, and lung protective strategies to be initiated within 24 hours. And from there, the protocol went. And people did it. People started jumping on board. People started reading the literature related to each of those particular variables, such that in 2008, these guys went back. They said, okay, we did this here. This, and this worked. And this didn't work quite so well. There were some questions with this. How do we adjust the bundles? And they did. And what they accomplished in the 4 years from 2004 to 2008 was they actually accomplished the changing of the name of the bundles. They made them prettier, but they say the exact same thing. So basically, they changed the name and they made them prettier. So, but they left all of this still together. And I will say that for the 6-hour or the quote-unquote new resuscitation bundle in 2008, everybody was firm. Everybody was good with all of these things. Nobody disagreed with measuring lactate, giving antibiotics, doing radiographic studies. You know, nobody argued with any of this. Nobody argued with giving a volume challenge in patients that came in hypoperfused. There was always the battle, and there always will be the battle of whether you want to use crystalloids or colloids. Personal choice, not getting into that today. And then there were questions about vasopressors. Which vasopressors should we use? Well, we did the literature search. We looked at it. You know, how does levo compare to vasopressin, compared to dopamine? All those studies were done. The VAST trials, the SOAP trials, they were all done. And what we found was the best vasopressor was Levophed, across the board. Vasopressin, we found, was not a great vasopressor, but that septic patients were vasopressin deficient, and we should be using that as a replacement dose between 0.02 to 0.04 units per minute to replace from there. Dopamine was not a good choice, and that went the way of the world. Well, when I was training, we loved dopamine. There was nothing like 2 mics per kg per minute for renal perfusion. Did it to all our patients. And some patients, renal perfusion improved. They peed more. It was awesome. Then we found out it was just we gave them fluids, so they peed. So dopamine didn't really work. So the SOAP trials proved don't use dopamine. So we kind of had an idea what to do with our vasopressors. And then there was always the question is, how are we going to monitor our patients to know where they are on their Starling curve? Are they fluid responsive? Are they fluid non-responsive? And everybody had an opinion, and everybody kind of did their own thing. But they still recommended using CVP or using SCVO2. As for the bundle, the management bundle, this is the bundle that got most of the controversy. Because the question was, should we use steroids, yes or no? Well, it depends on what article you read. If you pull 100 articles related to looking at steroids, 50 will tell you, yep, you got to use them, does great, decreases mortality. 50 will tell you, nope, kills people, doesn't do anything. So when the Anani article came out, early 2000s, it actually showed a significant improvement, clinically significant, of a 6% drop in mortality utilizing low-dose steroids. And low-dose steroids at that point were 50 Q6 or 100 Q8 of Solucortef. Everybody saw that, jumped on the bandwagon. Everybody was happy. You know, you heard the, everybody's great. We're going to use steroids. Everybody's going to get better. However, a couple years later, they decided, well, maybe that's not actually true, because you can't do a study and then not wait 2 years for somebody else to do a study to prove that you were wrong. Welcome to the world of critical care. So they did it, and they repeated the study, and lo and behold, they said there is no difference in mortality in patients treated with steroids or not treated with steroids. However, when you go back and look at the articles and you read them closely, the patients that were treated in Anani's first article were all in septic shock, they were all requiring vasopressors, and they were all treated within the first 8 hours. The second study, patients were first randomized after 24 hours. They weren't all in shock. A lot of them were severe sepsis patients. So therefore, there was a difference in the acuity. So my answer to you is very simple. If your patient requires vasopressors after an appropriate volume resuscitation, put them on steroids. It's not going to hurt them. And like I said, at this point in time, it was 50 Q6 or 100 Q8. As for Drotrocogen alpha, lots of controversy with this, because when this study first came out, the process trial first came out, people were like, oh my God, this is great. We're going to save the world. We're just going to give them this particular drug, and everybody's going to get better. And we did, and not everybody got better. The problem is, when this study came out, it came out after one study, when they released this drug. When they started doing further studies into it, they actually found that it didn't reduce mortality. It actually caused thrombocytopenia, coagulopathies, and bleeding problems and death, and they actually pulled this off the market. So this drug is no longer even available for anything. Activated protein C is gone. Glucose control. All right, tight glycemic control. Man, when the Vandenberg article hit in 2001, everybody read it in that November edition of New England Journal. Everybody wanted tight glycemic control. Everybody was going to be 80 to 110, because in the surgical ICU, it dropped mortality by at least 8.3%. It was fabulous. Everybody thought it was great. So what did they do? They repeated the article in the medical ICU, because let's face it, most surgical and medical ICU patients are a little bit different. So they repeated it there, and lo and behold, across the board, no difference in mortality. So people start smacking their heads against walls saying, well, why doesn't it work in medical ICU patients? Well, the answer is, don't read the abstract. When you see an article, read the abstract to see if you like the article or if it pertains to what you're looking at. If it does, read the article, not the abstract. Because what they found in actuality is that you're right. In the first 72 hours, tight glycemic control did not change morbidity and mortality in the medical ICU patient. After day three and above, mortality dropped, infection dropped, length of stay on mechanical ventilation, and use of CRRT actually dropped. So then the next question came, okay, we've proven that it will work, but are we really going to use 80 to 110? Kind of tight. Patients can get hypoglycemic. What if we take them a CAT scan? What if my other patient has a code? What are we really going to do? So the nice sugar trial came out, and they kind of compared different levels, and the actual answer to the question is 80 to 150. We finally had an answer to tight glycemic control. And then ARGNet. How are we supposed to mechanically ventilate our patients? This one has a lot of controversy. My answer to you is figure it out for yourself, because everybody does it differently. Everybody does it differently. They just picked numbers. You know, okay, we're going to go with 6. There's not a lot of science between comparing 4, 5, 6, 8, 9, 10. They just picked the numbers and went from there. What we do know is lower is better. Decreased volume trauma, decreased barotrauma, decreased rate trauma. All of those things go into play. Put patients on spontaneous modes, let them breathe on their own, let them pull what they need to pull. All of that we've learned from this. So there's a lot of controversy with that one. But that's where we were in 2008. And we figured it out. And we're like, okay, we're doing well, we're going to get there. And then, boom, 2012. Have you guys figured out every 4 years, for some reason, these guys like to get together? I don't know, maybe an Olympic thing, I don't know. But they got together back in 2012. And this time, they actually did make some changes. They looked at the severe sepsis criteria. And they went from what they had to sepsis-induced tissue hypoperfusion or organ dysfunction. And they kind of gave a list, again, very similar to what we saw earlier, but a little bit more specific when it came to organ dysfunction. And then they took a look at the resuscitation bundle, and they broke it down. This needs to be done within 3 hours. Lactate, blood cultures, antibiotic, volume resuscitation. After those 3 hours, these need to be completed within 6 hours. Now, it doesn't mean that you wait till hour 4 to do these 3. It just means these have got to be done first, then followed by whether or not they need a vasopressor, whether or not they need some form of measuring device, and then remeasure your lactate from there. Still, 2012, we were still looking at CVP, we're still looking at SCVO2, or normalization of lactate. Now, again, it goes right back to this, lactate. We talk about lactate, we talk about lactate, we push lactate. Why are we always talking about lactate? Because we have to, guys. If you have a patient who's in lactic acidosis and they are acidotic, nothing works. Nothing. Your vasoactive medications are not going to work. You've got to get the pH greater than 7.2 for your meds to work, for your vasculature to work. Your patients are not going to get better. So knowing your patient's lactate is extremely important because it's a surrogate for telling you how perfused or hypoperfused your patient is. Now, do I have anything that backs that up? Oh, yes, of course we do. There's article after article out there. One of the earlier articles came out in 2010 was Jansen's article. They compared using lactate with SCVO2 to try to optimize your patient. And they were looking at whether they can drop their lactate by 20% or more within 2 hours of resuscitation. If they did, great, keep going. If you didn't, they told them to go back up to the top of the chart and keep following your protocol from there. You had 2 groups. You had your lactate group and your control group. The only difference was that your lactate group, they knew their lactates. The control group, they didn't know their lactates. They just kept following the algorithm from there. And it was very, very similar to the early goal-directed therapy algorithm in how much fluids, blood, inotropics, vasodilators, and vasopressors they needed. And what they found, although it didn't quite hit statistical significance with .067, there was still about a 10% drop in mortality just following and normalizing lactate. And it actually held out to 200 days, and they followed those patients out. This particular study by Puskowitz and their group looked at the clearance of lactate. And this one's awesome in that if you clear your lactate in 6 hours, that 6-hour bundle, you clear your lactate in 6 hours, 93% of your patients are going to survive versus 67. 50% is 90 versus 68, and the numbers go down from there. So it's imperative that we clear our lactate. How important is it? Well, we can look at MAP, we can look at SCVO2, we can look at temperature for some reason. I have no idea why they looked at that. Or lactate. And what they found was, you know what? Patients had the best survival with clearance of their lactate. Worst survival, they didn't clear their lactate. We've got to reperfuse those cells to make them aerobic once again to make ATP for the body to function. So we need to follow our lactates. But one of the things that came out of all these bundles is that how much fluid should we give? We have to volume resuscitate our patients. How much fluid should we give? The problem is if we give too much fluid and we follow that with our CVPs, guess what? Higher your CVP, lower your survival. We do know that a positive fluid balance is prognostic. I mean, this particular study by Vincent and his colleagues showed you survivors did better with negative fluid balance. The more fluid the patients have, the more likely they are to have a poor outcome. But how do we know? How do we know how much fluid we give? We've got to know where a patient is on their Starling curve. Are they on the uprise where they're preload responsive, or they plateaued where they're preload unresponsive, or they've fallen off the curve over here where they're actually hypervolemic? And with that hypervolemia, all of this is occurring with organ dysfunction, secondary to organ edema, and rupture of the glycocalyx. And we need to know where is our patient on their particular phase of resuscitation. You know, are we in the rescue phase where we've got to get volume into them within minutes or they're going to die? Are they in the optimization phase where we know that they're not going to die right then and there from that, but we're trying to optimize their fluids and their perfusion to make sure that we're converting them back from anaerobic to aerobic metabolism? Have we stabilized them? Where we then go to pretty much a negative fluid balance, which takes us a couple days to get, or are we at the end where we're de-escalating? We may actually have to diurese them because they're starting to re-equilibrate where all their fluid is. Where is the patient on their curve for how much volume we have to give them? So we need to find that out. And for all of my critical care colleagues, next Thursday, we're going to talk about how we figure out where our patients are on their particular curve. Those of you that don't understand that, ask me later, I'll explain it to you. But one of the things that we got from these bundles was the use of something called SCVO2. SCVO2, mixed venous oxygenation, was one of those things that you never heard of until 2001. There's this new catheter that they were putting in that they were using for something called early goal-directed therapy. And they did it. It was a single-center study done in Detroit by Manny Rivers, Bryant Wynn, and their particular group. Manny was the attending, Bryant was the fellow at that particular time. Patients that hit their doors that met criteria for severe sepsis or septic shock within 1.4 hours were randomized to EGDT, where they had a catheter placed and all of these things were measured, or standard care where they had a catheter placed, but only these three things were measured. And what they were looking for was, does the timing of fluid matter in outcome? In the randomization, for the first 6 hours, all of the patients were in the emergency department. All of them were in the ED. The docs down there knew where they were. It was not blinded. They knew where the patients were. But at hour 7, they went up to the ICU. And the ICU docs were not blinded. They were blinded. And they randomized their patients from that standpoint and then went upstairs. So as you can see here, for the first 6 hours in the ED, EGDT patients got more fluid than the standard care. By the end of 72 hours, there was actually a 105 cc difference on average between the two groups. So it doesn't really matter when you get fluid. The answer is yes. You drop your mortality by 16% in hospital with early goal-directed therapy. 16% at 28 days, 12.5% by 60 days. In addition, you decrease mechanical ventilation, you decrease infection, you decrease CRRT. All of those things go along with early goal-directed therapy. So from there, people started saying, what is this SCVO2 of which you speak? I am not familiar. So people started doing research into SCVO2. And basically what it was a way to take a look at tissue perfusion. Are you perfusing your patients? Because remember, you're going to see a decrease in perfusion before you see a decrease in pressure. And also remember that adequate pressure does not mean adequate flow. As a matter of fact, 9% of Manny's patients in that first study were hypertensive. 140s over 90s are greater, but their lactates were greater than 4 and their SCVO2s were in the dirt. So what is SVO2? SVO2 is mixed venous oxygenation, the gold standard of that PA catheter. That everybody was putting it up until this point in time to measure a patient's perfusion, their oxygen delivery and consumption balance. Well, you know what? These two things have the same 4 factors that affect O2 delivery and O2 consumption. But when we measure them, mixed venous itself is in the pulmonary artery. It's an admixture of blood from IVC, SVC, and coronary sinus. We say shoot for 70%, right in the middle. SCVO2 is measured in the superior vena cava. It's an admixture of blood from the upper extremities in the brain. Again, we say shoot for 70. But if you compare these two together, there's about a 7% difference. And the reason behind that is because when you shunt the blood, patients that are critically ill shunt the blood from the vital to the non-vital organs to the vital organs. Non-vital organs are what? Skeletal muscle, skin, and GI tract. If you shunt from the GI tract, your IVC blood is less oxygenated. Therefore, your SVO2 blood is going to be lower than SCVO2, which doesn't have IVC admixture in it. Reinhardt was the first guy that took these two numbers and compared apples to apples. They used human subjects. Each particular patient had an SCVO2 and an SVO2. He drew them at the same time, and based on that, he tracked and trended it, and therefore the 7% number came from there. So based on all that, we actually vindicated it, and that's how it was used in early goal-directed therapy. And we used it forever. I mean, people jumped on the bandwagon. They were using early goal-directed therapy. A lot of folks were using SCVO2. This is for my surgical colleagues, especially my young ones. Measure twice, cut once. So go from there. So from there, everybody's doing it. Everybody was great. You know, this is fabulous. Then there's some guys at UPMC. And they're like, well, slow down. You got one center doing this study. We don't buy it. So the process trial was born. They looked at over 12,000 patients, eventually about 1,350 of them randomized, and they randomized them into 3 different groups. You had your protocol-based early goal-directed therapy, same as the last study. You had your standard therapy, same as the last one. Then they added something called usual care. Usual care was, you're the doctor, you do what you usually do. That sounds simple, I could do that. Their characteristics were the same across the board. But when you looked at the percentage of deaths, there was no statistical difference between the 3 groups. Based on that, people kind of went, well, wait a minute. Why are we doing all this if there's no difference in mortality? And across the board, even out to 60 days, out to 365 days, there's no difference in mortality. So the ARISE group and the ANZIX group came up. These are guys down in Australia and New Zealand, a couple patients in Korea. And they said, let's repeat it, but we're going to just do EGDT versus usual care. We're going to take out that standard arm. Characteristics, again, were the same. So are the results. And last but not least, the PROMISE group, which came out of Great Britain, again, did the same thing. But they broke it down. They actually looked at it for the first 6 hours, and then would be 7 to 72 hours upstairs. And again, the mortality wasn't any different. So all of a sudden from there, you started hearing people start screaming, why do early goal-directed therapy? It doesn't work, it doesn't work, it doesn't work. Let me tell you, it does work. And the reason why it works, and I thought this was perfect for this particular point in time in our conversation, is that it doesn't work because people are looking at numbers. Think about what usual care is. This study, early goal-directed therapy, came out in 2001, which means all the data collection was obtained in the late 90s. This came out in 2001. It was a landmark article. Everybody jumped on it. In 2014, when these studies were done, we'd all changed how we practice medicine. We all did all this. Usual care was early goal-directed therapy. We recognized sepsis, we recognized hypoperfusion, and we did all this. So in my mind, early goal-directed therapy works because it taught us how to be better doctors to treat this disease process. And if there was a difference between EGDT and usual care, then we're a bunch of idiots because we didn't learn what we should be doing to take care of these patients. And obviously we learned and we did really well. If you look at some of the studies very, very closely, like for example the PROMISE study in England, they only enrolled patients Monday through Friday, 8 to 5, because they didn't want to call anybody in at night. So look at these very, very closely before you start saying early goal-directed therapy doesn't work. Look at these studies very, very closely, because it does. So now it's 4 years later. It's 2016. So instead of redoing the bundles, they decided they were going to redo the definitions. Welcome to Sepsis 3. And what they did was they looked very closely and they said SIRS is overly sensitive and lacks specificity. And they said this part is very confusing. What is the difference between sepsis and severe sepsis? Because let's face it, if you're septic, you're sick. That's severe. Do we really need severe sepsis? So they looked at a couple things. First thing that they pulled was this particular article by Kokkonen and their group looking at whether or not SIRS helps in the defining of sepsis, severe sepsis. And what they found was that 1 out of 8 patients were ruled out. They didn't meet criteria using SIRS to define severe sepsis. 1 out of 8. 7 did, but it was that one guy that totally screwed everything up for us. In addition, they also looked at Sherpak's study, who said that, if you actually try to screen every single patient that's admitted, it'd be physically impossible to use SIRS criteria for that because so many people would meet SIRS criteria because they've been running up and down the stairwells that we can't use that as a marker for severe sepsis. And they actually looked at it. Looked at each of these particular criteria, what percentage were in admission, and the number of SIRS criteria at admission. Then they compared that to admission versus 24 hours. They looked at whether there was no dysfunction, new dysfunction, resolved dysfunction, or just sustained. And from there, they pretty much said, SIRS doesn't work. We got to come up with something else. It's not really something that we should be doing. So from there, Sepsis 3 was formed. There's 3 articles in this particular JAMA edition. The first one looks at defining sepsis and septic shock, taking SIRS out of it because they didn't like it as a criteria. They thought it was, and they looked at sepsis and said, well, it's more than infection in SIRS, so this is gone, period. They said that sepsis is going to involve organ dysfunction, so since this is going to involve organ dysfunction, we really don't need severe sepsis because that's what we defined as previously, so severe sepsis went away, and I shed many a tear because that was my favorite diagnosis. So the definition of sepsis is life-threatening organ dysfunction caused by dysregulated host response to an infection with an increase in the SOFA score of at least 2 points. So instead of using SIRS scoring, SIRS criteria, we now use the SOFA score. So based on that, we've dropped SIRS, we've dropped severe sepsis, we no longer use that, we're going to use SOFA scores and sepsis itself. The next thing they looked at was what should our definition of septic shock be? So we go from sepsis to septic shock, what definition should we use? And what they said is that it is a subset of sepsis. You have profound circulatory, cellular, and metabolic abnormalities, and the big difference is mortality. That's the difference. The difference between sepsis and septic shock is related to a mortality. And that was how they defined these particular two. And you can take it, this is a picture from one of the articles, and they're using Q-SOFA scores, we'll talk about in a second, is, you know, do they have positive for that? And you just kind of follow it as to whether or not the patient has sepsis or septic shock. In the third article that was presented, they kind of looked at something called the Q-SOFA score, and they looked at a bunch of patients from UPMC, again, all UPMC guys, and they compared SIRS, which they said we're not going to use because it's too sensitive and not specific. They looked at the SOFA score, which is 7 components. They looked at the logistic organ dysfunction system, which is the LOD score. And then they came up with something called the Q-SOFA, which is a very quick, easy way to do this. So look at your SOFA score, which looks at your PF ratio, looks at platelets, looks at bili, cardiovascular, looking at perfusion, CNS, and renal. There's 7 components, 0 to 4. And like I said, the diagnosis of sepsis now includes an increase of your SOFA score of at least 2 or more. The Q-SOFA is a very, very simple, quick screening test. Respiratory rate, altered mental status, systolic blood pressure. If they have 2 or more, they should be considered for having sepsis. And then from there, go to your regular SOFA score and make your calculations as to where the patient is from there. Predictability, when you look in your ICU, Q-SOFA does nothing for you. You really need to be using your SOFA score or your LOD score. In the non-ICU patient, it's a quick, easy screening exam to determine who has sepsis or is at risk for sepsis and who doesn't. Should we add lactate? This says to the Q-SOFA score, it does not increase the predictability of a patient who has sepsis or will develop sepsis. It's used more so once you make the diagnosis, measure your lactate, how sick is that patient, and where do we need to go from there. Sorry, guys, I thought it was hysterical. Thank you, ladies. So this was released. They actually released it at Society of Critical Care Medicine with the release of that particular JAMA edition. People went crazy. It was nothing like seeing 5,000 people rush the stage for 50 copies of a journal that you can touch on your phone and get the whole thing online. But it was great to watch. But after it came out, you knew that people weren't going to roll over and just say, okay, sounds great, we'll do whatever you say. As a matter of fact, right after that came out, starting in March and April, you started to see editorials in a lot of major journals saying, no, we're not buying it. Matter of fact, in American Journal of Respiratory and Critical Care Medicine, this came out. And they said, great, but the decision to revise the definition should be based on unambiguous new developments in the field rather than expert opinion. Translation, we've been dealing with this for 25 years. We haven't come up with any new therapies, no silver bullets. And trust me, we've done a lot of clinical research and a lot of clinical research trials, but there's no silver bullet. So why are we changing the definition of something when we haven't come up with a new treatment modality? And they looked at several issues with it. 1, they looked at SOFA versus SIRS. 2, they looked at organ dysfunction. 3, proper representation, 4, gold standard, and 5, again, what I just said, how specific is this? And breaking it down, when they looked at SOFA versus SIRS, they were basing it, number one, on the inclusion of pro and anti-inflammatory responses. No new information there. We've been trying to find the silver bullet for 25 years, which is going to either improve pro or decrease anti-inflammatory responses. They looked for a study to validate these SOFA scores, and they couldn't find one. And they also looked at these cutoffs, and they were so arbitrary that they felt that it was pretty misleading because this isn't a homogeneous disease process. Every patient that has sepsis or septic shock is different. Everybody is different. And to have a specific number that says X is the cutoff doesn't really work. So there's a lot of argument right now whether or not we should change the definitions and go with these new recommendations just based on the fact that everything's based off a SOFA score. People aren't agreeing with that. Another thing that they said was that they want dysregulation even to make the diagnosis. Well, think about that. Your goal as a clinician is to recognize sepsis as early as possible, antibiotics, cultures, fluids, measure lactate, all those things is the cornerstone. So shouldn't we be recognizing it before dysfunction and dysregulation to prevent organ injury? For example, right now, if you have a fluid-responsive hypotensive patient who has an infection and they get better, they're now defined as uncomplicated infections. They're not septic. And how septic is septic? Those things come into play. Also, when they looked at the task force, there was nobody from lower middle-income regions. These are all high-income regions that were on the task force. Emergency medicine does not recognize this. Physicians from these regions are not recognizing the new definitions. They're sticking with the old ones. Like I said, 25 years of clinical trials, there's nothing new. So you're starting to see a lot of argument as whether or not we should change the definitions based on what these guys want, but nothing else has changed. And everybody knew what those were. Everybody was doing well. They knew the therapeutic interventions. They knew where the patient was on their spectrum, and they were able to treat them from there. So there's kind of a question, so are we really going to all do this? Because there's a lot of, you start pulling up articles, there's a lot of editorials where people are arguing, and there's big names that are arguing. And you got Paul Merrick writing articles saying he's not buying into this. You got big names that are fighting it from there. But to summarize it, this is sepsis 1, sepsis 2, and where we are today with sepsis 3. So with that, because I can, first time in how many years the entire National League infield at the All-Star game is what? That's right, baby, all Cubbies. So if anybody's got any questions, I'll be glad to answer them. Otherwise, thanks for your attention, and I think there's another conference coming in a few minutes. Thanks, guys.